Prasad, consultant radiologist in Vijaya Diagnostic Center, Hyderabad. I welcome you all for another episode of Clinico-Radiological webinar series, where we have mutual discussion between the clinicians and the radiologist for exchange of knowledge, for better patient care and management. Today's topic of discussion is the role of myocardial strain in cardiac MRI. I'll be moderating the session, and to discuss the topic, we have two eminent faculties in their respective fields. Our today's first faculty is Dr. Sanjeeva Kumar, sir. He is also today's session. Welcome, sir. About introduction of the sir. Sir has done MBBS from Usmania Medical College, Hyderabad, MD Medicine from Usmania Medical College, Hyderabad, and sir has done DM Cardiology from prestigious Nizam's Institute of Medical Sciences, Hyderabad. And sir has previously worked as assistant professor in medicine department in SVS Medical College in Mehboob Nagar, where he developed MICU and intensive care units in the hospital and trained nursing and technical staffs in the critical care areas. Sir was also teaching faculty for postgraduate students in internal medicine. Sir has got vast clinical experience in cardiology and worked in various hospitals, reputed hospitals previously in Hyderabad. Some of them are Usha Mullapudi Cardiac Center in Hyderabad, Care Hospitals, Hyderabad, Continental Hospital in Hyderabad, and Citizen Hospital in Hyderabad. Sir is currently practicing as senior consultant cardiologist in Apollo Hospitals, Jubilee Hills, Hyderabad. On behalf of Vijaya Diagnostic Center, I thank you, sir, and I welcome you, sir. And would like to again thank you for taking out your time for joining the session. Welcome, sir. Our second faculty for today's discussion is Dr. Chilkuri Sushmita Keerthi. She is a practicing consulting radiologist in Vijaya Diagnostic Center, Hyderabad. She has done her MBBS from CMC Vellore and DNB from Care Hospital, Hyderabad. She holds degree of FRCR also. And Madam has done fellowship in thoracic imaging from McGill University, Montreal, Canada. She has also fellowship in cardiothoracic imaging from Sunnybrook Health Sciences Center, University of Toronto, Canada. And she holds a degree of Medical Council of Canada qualifying exam. Her previous radiology experience includes working as consultant radiologist in Amma Scan Center in Cochin, Kerala, Lutz Hospital in Cochin, Kerala, Burjil Medical Center, Muscat, Oman, and Badr Al Sama Medical Center in Dubai. Again, coming to today's topic, role of myocardial strain in cardiac MRI. Now, I request our chief guest, sir, Dr. Sanjeeva Kumar, sir, for his opening remarks on the topic and to enlighten us where these imaging findings can be helpful. Over to you, sir.
Oh, thank you. Thank you for inviting me. So today's topic is myocardial strain. Basically, for especially cardiovascular patient, heart failure patients, we have three groups of patients. One is heart failure with preserved ejection fraction, that comprises 1/3, and heart failure with reduced ejection fraction, that comprises 1/3. And third group is mixed. They heart failure with borderline ejection fraction, like around what we call is ejection fraction 40 to 50%. So basically, heart failure with reduced ejection fraction, as you all know, that is they land in irreversible heart failure. So where treatment options will be limited. And the main focus would be here. The topic main focus will be on heart failure with preserved ejection fraction, where there is a subclinical LV dysfunction is developing in those patients, where routine 2D echo, what we do will not be able to pick out these group of patients. So we'll label them as heart failure with preserved fraction and treat them accordingly. But with newer advent of the technology advancement, so where we use speckle tracking echocardiography or myocardial strain, as we are going to discuss, we can able to pick up these group of patients in the early stages before LV dysfunction sets in, and we may address these patients with the newer like anti-heart failure medications or all the progression of the LV dysfunction. So previously, especially the main role was speckle tracking echocardiography in anti-cancer chemotherapy cardiotoxicity, where we used to perform these patients who are receiving especially anthracyclines and other cardiotoxic drugs in chemotherapy patients to assess the serial assessment for the subclinical LV dysfunction group of patients. So we had almost quite a number of patients where we intervened and just stopped the medication or adjust the dose of the medication of cardiotoxic medication. That is one group. And another group of patients where we frequently use this speckle tracking echography cardiomyopathy patients like ischemic cardiomyopathy or dilated cardiomyopathy or hypertrophic cardiomyopathy, also group of patients where we can identify these early patients, especially hypertrophic cardiomyopathy, before they develop into LV dysfunction. And another group of patients where this was useful was LV dysynchrony, cardiac desynchronous therapy. That is to specifically identify the source of pacing site. So that way we used to have this speckle tracking recovery. Another group was especially congenital heart disease, where I don't have much this expertise, especially post-op patients or pulmonary hypertension, where to assess the RV function. This RV function is best assessed by cardiac MRI, or congenital heart is also best assessed by cardiac MRI. And now with the advent of this myocardial strain, another modality, post-processing modality of routine cardiac MRI, I think this may give some more better information in especially subclinical LV dysfunction patients.
Thank you, sir.
So
Thank you for the clinical input, sir.
We go to the topic and to just acknowledge ourselves, to update our knowledge based on that speckle tracking.
Thank you, sir. Thank you for the input, sir. Over to you, Dr. Sushmita, madam. You may please proceed with the topic.
Thank you. Yes. Am I audible?
Yes, madam, you're audible.
Yeah, okay. So good evening, everybody. So today's topic is strain in cardiac MRI. So before moving on to the actual topic, I thought I'll just mention about the basic sequences we do, because not everybody is well versed with the sequences. I'm not going to deal with the physics bit of it, but then I'll just mention what we normally do. So we do something called the white blood imaging, which is SSFP sequence. So that is used to assess the function and the anatomy. Then the black blood imaging is to assess the anatomy. Then we can characterize the myocardium using LGE, or we can use parametric mapping. And in patients who have valvular regurgitation or shunts, we can assess the flow, we can quantify the flow using phase contrast analysis. So this SSFP it's like the bread and butter sequence of cardiac imaging. It's a white blood technique, and the acquisition generally is done over several heartbeats, but within a single breath hold. And these are the planes in which we normally acquire the images. So this is the 2-chamber view. This is the 4-chamber view. This is a 3-chamber. The 3-chamber, this is a stack image, so it will load slowly. And this is a short axis. So we acquire the images in 3 long axis planes and 1 short axis plane. So before moving on to the tissue characterization and all, I thought I'll just mention about the AHA segments. So normally when we report the characterization in MRI, we have to specify, or the wall motion abnormality for that matter, we have to specify which segment of the myocardium is abnormal. So for this, what has been done is, so this is the basal cavity, the mid cavity, the apical and the apex. So at each level, we have the American Heart Association has divided the myocardium into segments. So the outermost ring, so this is the bullseye view of the segment. So the outermost ring over here is the basal cavity, which has 6 segments. Then you have the mid cavity, which has 6 again AHA segments. AHA is the American Heart Association. And then you have the apical, which has 4. And then you have the true apex. So altogether, we have 17 AHA segments. So whenever we are reporting any abnormality in cardiac MRI, we have to specify which AHA segment is abnormal. So I just mentioned it over here so that we can understand the subsequent slides. So as I mentioned, the SSFP is one sequence, which is to assess the cardiac function. Then coming to characterization, we have this LGE. So this is an inversion recovery sequence. So inversion recovery, what we do is we use specific TI time to null the myocardium. So the signal of the myocardium, if it's bright, we will not be able to make out any abnormality. So our aim is to make the myocardium, the blood should be bright and the myocardium should be null. So at that point, the abnormal myocardium, which picks up the gadolinium, will stand out as a bright signal. So as you can see over here, this is all how the normal myocardium will appear. And this is the abnormal myocardium. So this helps us in characterizing the abnormal myocardium. So this is how exactly how the late gadolinium will help us in differentiating few conditions. So you can see there is enhancement in the subendocardial region, whereas over here you can see there is a transmural enhancement. And in other conditions, you can see there is patchy. There can be diffuse subendocardial, or there can be some patchy subendocardial enhancement in amyloidosis and some low flow endocarditis. And you can see mid myocardial enhancement in conditions like HOCM and dilated cardiomyopathy. Then you can see subepicardial enhancement in myocarditis and sarcoidosis. So this is one way to characterize the myocardium. Then the other sequence, as I already mentioned, is a phase contrast imaging. So this is basically, it's analogous to the Doppler. This is useful mainly in intracardiac shunts and valvular regurgitations. Then off late, we have new sequences like the parametric mapping. So these parametric maps, what they do is they help us in quantifying. We can actually get the values, the native and the post contrast, the T1 and the T2 values of the myocardium. So this will help us in differentiating all these different types of conditions. Like for instance, you can see in Fabry's disease, your native T1 value is lowered. So similarly, in iron overload, in conditions with iron overload, your native T1 time and your T2 time both are lowered. Whereas in conditions like amyloid, you can see that the T1 values are elevated. The T2 is more specific for edema, so the T2 values will be elevated. So this is also relatively new kind of imaging, cardiac imaging, which helps us to quantify the T1 and T2 times of the myocardium, and very helpful in differentiating certain conditions. So now coming to the actual topic, which is strain and cardiac MRI. What I'm going to deal with is, first I'm going to say what is the role, what is the anatomy behind it, what is the principle, and then what is the role. So why has this concept of strain come into existence? Ejection fraction is actually not very sensitive for detecting early myocardial injury. So by the time the patient has an abnormal EF, the myocardium has already sustained damage. So what is the goal of imaging? So we actually want to catch the myocardium when it is in the early stage of its dysfunction, so that we can prevent further dysfunction. So that is the aim of our strain. Now coming to the principle, if you look at the way the myocardial fibers are arranged, it's not like a uniform arrangement. So the subendocardial fibers, usually they're arranged as a left-handed helix. So when they contract, there's a longitudinal shortening. So the base of the heart is pulled towards the apex. When the mid-wall contracts, there is a radial shortening. And when the subepicardial fibers contract, there is a circumferential shortening, which I'll explain in a diagram. So if you can see, there are three types of shortening that the myocardium undergoes whenever there's a contraction. So this is called, when it happens in this direction, it's called a circumferential shortening. When the myocardium thickens, it's called a radial shortening, and then there is a longitudinal shortening. So this is a principle of strain. So by convention, what we do is we start with the myocardial length in end diastole and see what is the length of the fiber in end systole, and then you subtract the end length of systole and diastole. So suppose, for example, if it is 6 over here and then it becomes 10, it becomes 10, then you have to subtract 10 and 6. So you'll actually, if you see the original fiber length and the final fiber length, if it's shorter, then you'll get a negative value because this is smaller. So, but the radial strain, if you see, you actually gain thickness. So it's a positive value. So if you see your longitudinal strain and circumferential strain, it will become more negative compared to your original value. But your radial strain, when it contracts, you gain. So your radial strain values are usually positive, but your circumferential strain and your longitudinal strain values are usually negative. This is a normal myocardium, how the values are in a normal myocardium. So this is the formula actually which the software uses. I mean, this is a principle behind it. It's called the Lagrangian strain, which gives us these values. So radial strain values are all usually positive, and your circumferential and longitudinal strain are all usually negative values. So coming to the MRI techniques, we have different types of techniques to calculate the strain, but the most commonly used technique is called feature tracking. So what the machine detects is, suppose there was a speckle in diastole in this position, and in systole the speckle moves to this position. What is the displacement? So that displacement will tell us the change in the fiber length, and it automatically calculates the strain values. So let me just show you how it's done. So as I already mentioned, so we do get 3 kinds of strain values. The longitudinal strain is one, which is most commonly used, and it's acquired in long axis views. Then you have the circumferential strain and the radial strain, which are the short axis values. And this strain can, the beauty of the strain is that you not only can calculate global values, but you can also get segmental. Then you can calculate the value in the subepicardial and the subendocardial region separately, then separately at the base and the apex. And you can also calculate the strain rate, not just the strain. So the strain rate will tell us what is a peak systolic strain rate, what is a peak diastolic strain rate, and what is the time the myocardium is taking to reach that peak strain. And there's another thing called the torsion angle, which is not used much, but that is supposed to help in the evaluation of cardiomyopathies. So these are some of the factors which affect the strain. That is software. It differs from vendor to vendor, and it differs from the strength of the magnet we use. Usually at 1.5 T, the values are a little higher than a 3 Tesla. And the patient demographics, usually we have higher strain values are usually seen in women. And also as the age increases, the strain values are lowered. And hemodynamics, usually the heart rate is high, also your strain values can be lower. And exactly how we do it is we contour the ventricles. So we can do it for the RV as well. Like this, you contour the endocardium and the epicardium. So we do it in all the planes. So this is the 3-chamber, the 2-chamber, the 4-chamber, and this is a short axis. So once we contour all the planes, there is an option over there. We have to do the contouring, because when it auto contours, it usually doesn't do it well. So we have to manually adjust all the contours. And once we do that, there's in the application, we just have to click on strain. And once we do that, it automatically gives us these strain curves. So these curves actually tell us like what are the values in the epicardium, what are the values in the endocardium, and all these are like in the different AHA segments. And the pink one is one we are interested in. Like whichever we are interested in will appear as pink, and it will give one full curve for the entire myocardium strain curve. So like that, you can get different types of strain values based on what we are looking for. And this is how typically the strain curves look like. So be it on echo or be it on MR, they look the same. So a radial curve, a normal radial curve is usually a positive curve like this. So you can see that the myocardium, as it shortens, your radial strain value goes up to a peak positive value, and then it comes down. Whereas your circumferential and your longitudinal strains, they are usually on the negative side, and they usually become very negative, and then they return to the baseline. So as I already mentioned, we can calculate in any specific segment of the heart, wherever we are interested. If we have a doubt in any specific area of the heart, we can just place the ROI in that particular segment, and it will give us the strain value in that particular segment. This is a bullseye view, just like how we see in echo in the MR as well. In each AHA segment, we can see, so this was a patient of amyloid. That's why you can see all the values are on the lower side. So in echo, we can get at the true apex as well. But here, the MR machine would not give for the true apex. So we have for the 16 AHA segments. So this is a peak longitudinal strain, the peak circumferential strain, and the peak radial strain. It'll also give us strain rates, similar type of bullseye values for a strain rate as well. So likewise, for the right ventricle as well, it can be calculated, not just the left ventricle. And the strain curves look more or less the same in the right ventricle as well. So there are several studies. The meta-analysis has been done. There was a meta-analysis of around 23 studies, which included around 1,782 healthy subjects. So from these subjects, they derived some normal cutoff values for the different strains. So for the LVGLS, which is the most important strain parameter, the minus 18 is a cutoff. So anything which is more positive than that, in the sense which if anything goes below that, then it's considered abnormal. Likewise, for the GCS and for the GRS also, we have cutoff values. And also for the RV, we have somewhat similar values. So for the RV, if the GLS is more than minus 17.4, it is abnormal. The atrial strain as well can be calculated, but unlike the ventricles, here the strain curves are a bit different because the atria has a different function of a reservoir, a conduit, and a booster. So for the left atrium, we normally contour it in the 2-chamber view, and sometimes we can do it in 3-chamber as well. But if we can do it in the 2-chamber and the 4-chamber, that would suffice. And for the right atrium, usually we contour it only in the 4-chamber view. And this is how typically an atrial strain curve would look like. So it has 3 parts to it as depicted over here. So from this, we can actually derive the atrial strain values. So this is how, and these values are not from, this is not from the internet. These are all values, graphs, which I got it during my research. The normal values of left atrial strain, these are the values from the, again, from different studies, the reservoir, conduit, and the booster values. And left atrium strain analysis of late has found to have a lot of significance in patients with HCM, then heart failure with preserved ejection fraction, and ischemic heart disease. Now, coming to the clinical applications of strain, it's found to be very useful in the early diagnosis of certain conditions. Most importantly, cardiotoxicity of anti-cancer drugs, then in ischemic heart disease, non-ischemic cardiomyopathy, and like Sir had mentioned, in certain congenital conditions as well, like pulmonary hypertension. Then it's used for prognosis and risk stratification. Like in ischemic heart disease, it'll help in identifying segments which will recover function or not. So it's along with the LGE, if you have a strain value, probably you can convey better to the clinician whether the segment is viable or not. Then it's helpful in non-ischemic cardiomyopathies. I'll talk about it in the subsequent slides. Then valvular heart disease. Then therapeutic decision-making in LV dysynchronies, because the time to peak will differ if the patient has LV dysynchrony. So it will differ in the different AHA segments. Then family screening is very useful in patients who have HCM and muscular dystrophies, where grossly the myocardium may appear normal. But then when you do the strain value, probably you may pick up early dysfunction. So coming to cardiotoxicity of anti-cancer drugs, mainly patients who are on anthracyclines, then immune checkpoint inhibitors, and signaling pathway inhibitors like trastuzumab. These are the drugs which are most extensively studied. So the patients are actually stratified based on their risk factors. So there are medication-related risk factors and there are patient-related risk factors. So put together, there is an overall cardiotoxicity risk score derived. So if the patient has a score of or greater than 6, the patient is at a very high risk of cardiotoxicity. So these kind of patients, once they are stratified, certain recommendations have been laid by the Mayo Clinic that if there's a very high chance of cardiotoxicity, then you do a transthoracic. So this recommendation is for echo, not for MR. So you do a transthoracic echo with strain before every other cycle. Then you repeat it every 3 to 6 months and 1 year. So they've sort of incorporated strain into their routine imaging. So this is an example of a patient who's on a chemotherapeutic drug. So as you can see that this particular, the mid-inferolateral wall just stands out. It's just -3. So if this patient had normal baseline strain value, and we can see that during the course of treatment, there is the one segment which is showing abnormal strain, so it should sort of ring a bell that probably there is early cardiotoxicity setting in, and we have to probably intervene or stop the drug or do something like that. So here we can see that this area, it is low. So this overt cancer drug-related dysfunction has been defined as a left ventricular ejection fraction drop 10% points to a value of less than 50%, or when the LVEF drops 20% from the patient's baseline value. That's how we monitor. And then the American Society of Echocardiography, the European Society of Cardiology, and the American Society of Clinical Oncology what they have defined it, the toxicity as, is a relative global longitudinal strain drop cutoff of greater than 15% when we compare to the baseline. Significant, but change less than 8% is not significant. So during the course of treatment, we monitor serial GLS values, and whenever it drops greater than 15% from the baseline, probably there is early myocardial toxicity setting in. Likewise, for the RV-GLS, they've said that a change of minus 14.8 predicts cardiotoxicity. So the future prospects are that probably we can initiate cardioprotective medication triggered by reduction in the GLS in these kind of patients. And in ischemic heart disease, the GLS, the global longitudinal strain, and the global circumferential strain can give us good information about the viability, and we don't need any stress agents to detect any wall motion abnormality. On the routine SFP sequences, we can do all this. We don't even need contrast for this. So in myocardial infarction, it is supposed to correlate directly with the size of the infarct, thereby helping us to better distinguish subendocardial from transmural infarcts. So this is a patient whom we can see has an infarct in this area. We can see there is delayed gadolinium enhancement pickup, and we can see this pink one corresponds to that particular AHA segment where the values, the strain values are very low. So when the strain values are very low, what is said is that the recovery is very poor. In heart failure, a lot of studies have been done on the left atrial strain. So there are systematic reviews and meta-analysis also done. And what they have concluded is that the peak atrial longitudinal strain was an independent predictor for all-cause mortality and cardiac hospitalization in patients with heart failure. So the left atrial strain is also significant. It's not just the ventricular strain. And coming to the role of strain in non-ischemic cardiomyopathies, it's very useful in early detection and risk stratification. Like for instance, in conditions sometimes in myocarditis where it's difficult to differentiate even on routine MR, probably it will help us because even though there may not be any LGE, but your strain values will definitely be lowered. Similarly, in ARVD and dilated cardiomyopathy, HCM, amyloidosis, sarcoidosis, and all these conditions of non-ischemic cardiomyopathy, also strain is found to have a significant role. So, I mean, these are the LV hypertrophy. Similar in all these conditions, some of them are non-ischemic as well. Sorry for the spelling mistake. So, different causes of LV hypertrophy like hypertension, aortic stenosis, HCM, storage and infiltrative disorders like amyloidosis. It helps us in early diagnosis, and the management of each condition differs. So it's very important to diagnose this LV hypertrophy correctly, and it helps us in this. So this is a picture where we can see that these are all conditions which can have LV hypertrophy. So this in a normal subject, we can see the mean global circumferential strain and the global longitudinal strain. These are the values. It's around 22, minus 22, and minus 22. So this there's a condition called athlete's heart where there's hypertrophy, but it's not a pathological hypertrophy. So your strain values are normal. So if you encounter a patient who has hypertrophy and you have normal strain values, you are assured that it is not pathological. And then you have hypertensive heart disease and hypertrophic cardiomyopathy, where the strain values are lowered, but not as much as amyloid, where you can see your global longitudinal strain is significantly lowered. It can go down to even -4, -3. So in all these conditions where sometimes your routine MR sequences, including LGE, can be a bit confusing, your strain can help you to better narrow down your differentials and come to a proper diagnosis. And often they say that even in valvular heart disease, it can help us in early diagnosis of cardiac dysfunction, like in aortic and valvular heart disease. It's very superior to LVEF. And normally circumferential contraction, it compensates for the reduced longitudinal contraction, and it somehow maintains the LVEF for some time. So if we can pick up this early dysfunction and contractility, then we can probably better manage the patient. This is apparently some centers do this for patients with severe aortic stenosis and preserved LVEF. So they do the LV-GLS, and if the LV-GLS is less than -16, they do cardiac MR. And if the cardiac MR is showing abnormalities, they intervene, otherwise they follow up. So likewise, they have different categories. They have divided different types of follow-up for different kind of patients who have GLS values above 18 or below 16.7. So coming to the limitations of strain, it depends on the heart rate. As I already mentioned, it differs with the age. And sometimes there can be an intra-observer variability because of the contouring. It has a substantial learning curve, and differences in value with different vendors have not been studied. And the software is quite expensive. That is one of the main limitations of MR strain. The take-home message: multi-chamber cardiac strain as a novel tool for early diagnosis, disease staging, narrowing differential diagnosis, and prognosticating several conditions. We do not need to administer contrast. It is very easy to perform. There is consistency across studies. Thank you.
Thank you very much, madam. It was an excellent talk and elaborate presentation on the myocardial strain. We have been hearing about T1, T2 mapping and ECV values, but this is something new which is coming up, and one of the important recent advances where we can pick up the pathologies before the LV ejection fraction drops down. Thank you, madam. Over to you, Dr. Sanjeeva Kumar, sir. Over to you, sir, for your comments and any questions.
Yes. Yeah. Basically, till now we are only just sending the patients for cardiac MRI, especially late gadolinium enhancement to look for any scar tissue in various group of cardiomyopathies, hypertrophic, amyloidosis, sarcoidosis. And we used to correlate with speckle tracking echocardiography also on these patients. But rarely this is actually, I also don't know much about the myocardial strain. I'm also just updating for the first time. Maybe I think it has a better role in prognosticating or just narrowing down the differential diagnosis, especially in hypertrophic cardiomyopathy, amyloidosis group of subset of patients, or sometimes ischemic heart disease patients also, where we have to intervene, where we have to go for CABG bypass or stenting if there is viability. And also especially CKD patients where we are afraid to give gadolinium, especially in subset of patients, especially amyloidosis, other group where creatinine is borderline. So we can go for this myocardial strain. Only thing is, as it said, that it's quite expensive, so we have to also see the financials for the patient.
Yes, sir.
As it said, any centers in Hyderabad they're planning to start this?
I think we in Vijaya Diagnostic, I think we are coming up in shortly, sir. Maybe in a couple of months we are going to have it.
Because yesterday, 2 days back, we have one patient presenting with heart failure, and there is some signs of restrictive cardiomyopathy-like features. So I think we need to assess cardiac MRI and this cardiac strain better.
Yes, sir.
If it is about to start, then we'll send that patient.
I think they start doing parametric mapping, but I don't know whether strain software they are going to buy. But I know they're getting parametric maps.
So anyway, we are planning for cardiac MRI once the heart failure gets resolved. And if it is also, then we can have this myocardial strain also for cardiac MRI.
Yes.
Yes, sir. One question in the chat, madam, for you, Dr. Sushmita.
Yeah. Yes.
Madam,
yes, yes, sir, please.
I think this training is also very important. It seems. I think not much radiologists will be aware of this myocardial strain, so they should get trained, I think.
Yes, but actually there's not much training needed. We just have to contour, and the software automatically calculates it for us.
Yeah. That's
so
okay.
Yes. So it's
there is not much stress on the radiologist.
No, it's actually no.
Because yes, if we want to do speckle tracking, we have to spend at least half an hour. So after the images, and we need to spare half an hour for the patient to get good images and to point the various segments, and then we have to get the curves, all those things, and then to interpret. It takes minimum 15 to 30 minutes. Nowadays, 4D echogram they will give, but at least interpretation is more important than what they give. So for you, I think it's not a problem.
No, it's not. No, it doesn't take time. Because anyway, we do the contouring to get the ejection fraction and the volumes. So the same contours we can use for strain as well.
Yeah.
One question for you, madam, in the chat, Dr. Sushmita. Do these findings
Yeah.
of myocardial strain, these findings of myocardial strain in MRI, they correlate with the findings of echo?
Yes, they are actually comparable. Most of the studies have found that the values of echo and MR are actually very comparable.
Right. Okay. Good. Any more questions? I'll just see in the chat. Yeah, no more questions as of now. So with your due permission, sir, and Dr. Sanjeev, sir, I would like to, we had good discussion about the topic, and
Yes, sir.
since we are yes, sir, since we have discussed the topic, we would like to close the session with your due permission. Thank you, sir, for joining us.
Okay,
Thank you once again.
So please
Thank you,
update
madam.
us, sir. Whenever you are starting this myocardial strain, please update us
Sure.
so that we can help the patients.
Sure.
Yes,
That's one
definitely,
thing.
sir. Thank you. Thank you for the talk. I would like to thank Vijaya Diagnostic for giving us this opportunity for conducting the webinar, and also would like to thank the technical and supporting team for conducting the webinar. Thank you, sir. Thank you very much, sir. Thank you, dear all.
Thank you.
Thank you.
Thank you.